last time we talked about basic growth processes. And for a number of years, I've always done maxilla next. But I was thinking about it, and actually what makes more sense is to do cranium and cranial base next, and then do maxilla next time. So we'll start and we'll work our way down now that you know the basic processes. So that the basic concepts, the basic way bones grow, there's only two, okay? So if I asked you, how does the face grow? And you said, well, it grows out from underneath the brain, that would be correct, okay? But you'd also have to now add to this, to be correct, you'd have to say, Dr. Hans, it grows out from underneath the brain by displacement of bones and remodeling, okay? So remodeling and displacement. And remember that remodeling is the surface stuff, right? And displacement, when we had everybody sitting here, is pushing everybody around on the neck. That's movement of the whole bone. So no matter, from now till the end of this course, it's always going to be the same thing. When we talk about bone growth, it's going to be those two processes, displacement and remodeling. Okay, so what about the skull? Okay, what about the skull here? And I decided that rather than start with the face, let's start with the cranium, and let's talk about what's going to happen here and how is the cranium going to grow. How are these bones going to grow? And so who's got pretty good hands to catch this? No? All the way to the back? Nice catch. Okay, so one thing that you'll notice, and I have some here that we can pass around, is that on young growing skulls, the flat bones of the skull are not connected, okay? So the flat bones are not actually connected together. And some of these skulls, they actually glued them together so they wouldn't fall apart. So when we have one flat bone of the skull connected to another flat bone of the skull, we have something that fits in between. What I think Mike probably was just talking about that, right? It's a suture. Exactly, it's a suture. So we have sutures between all of the cranial bones. So if you look at, for example, some of those skulls that are going around, you could see the temporal bone, right? And then you've got the parietal. Okay, so the question is, what happens when the cranium grows? What are the processes that are involved? Remodeling is one, displacement's the other, okay? You can never be wrong by saying remodeling and displacement. So the question is, so when we're growing the cranium, okay, when we're growing the cranium, the brain is expanding. So the brain is expanding, and the brain, unlike bones, can grow interstitially. So your brain is capable of interstitial division. In other words, neural cells can grow interstitially. Okay? We can also get increases in cerebrospinal fluid. We can get increases in the entire, the soft tissue of the brain, not just the cells, but the whole brain. And it's growing. Now we know that the brain starts almost fully grown, but not totally fully grown. So what happens when the brain grows? So imagine this, it's like a balloon almost, right? It's a balloon with a bunch of just little sutures, right, that connect it together. As the brain grows and divides, what happens at those sutures? Displacement and remodeling, okay? Displacement is when the two bones are moved apart. Why do we know that it's the growth of the brain that causes the enlargement of the skull and not growth at the sutures pushing the bones apart? There you go, exactly. that bone can't push on other bones. And it can't push on other bones because of the way the tissue is constructed. It has the periosteum. So all of these sutures are lined with periosteum. Right? All of the sutures are lined with periosteum. So when the brain grows, we displace the flat bones of the skull, and then we get bony deposition in the sutural areas. So pacing growth of the cranium is brain, not bone. Okay? So somebody asked me what causes displacement. And the reason why I thought we'd start with talking about the cranium like that is because in the cranium, it's pretty clear that the way the flat bones of the skull get displaced is by growth of the brain. Okay? Why do we know that? Well, first of all, we can do animal studies, and if we put across the metopic suture here, if we put implants here, okay, if we put implants like I'm showing you right here, if you put implants in the bones, okay, and the implants are moving apart, okay, but staying in the same relative position, they're moving apart, we would know that that bone is being displaced. Does everybody see what I mean by that? Okay, notice if we have a label there, we can put it there, or a pin, we could drive up, you know, some of the early people would take like a mallet, like I have my mallet there, and we could take like a little lead implant, and we could pound one into the bone. And they actually did it in humans, hard to imagine. But they said they'd wrap them in, and then they'd watch how those implants would move over time. So you know that the implant can't move. In other words, that bony implant like that, this is like a growth implant. And why do we know that that bony implant can't grow? Why do we know that something we stick in there? If you got shot and there was a piece of the bullet that got lodged in the bone, it would just stay in the same exact spot. But why? Why is it going to stay in the same exact spot?
New bone grows posteriorly.
Because it can't grow interstitially, and so once it's there, so there's only two options, right? The option one is it becomes integrated with the bone, right? And the other possibility is the body sequesters it out because it's a foreign body. So you're either going to get a foreign body reaction, it's going to be sequestered out, or you're going to get, it's going to be integrated with the bone. Okay? The same thing what happens when you're doing an amalgam. And we don't do any amalgams anymore, but you know, with mercury and the lead in the amalgams, we still even do amalgams? Okay, so at least you like that makes some sense. Okay, so you can use amalgam as an implant, right? So sometimes when people were using a high speed, they were cutting out old amalgams and things, they would, you know, stuff would get stuck in the gingiva, or you could see it on the x-ray, it would pierce that, and then so when it's in the soft tissue, it's going to grow with the soft tissue. If it's in the hard tissue, it's going to stay in the same spot. So, the brain is growing, and we know that the brain is capable of pushing the bones apart because the brain is soft tissue and capable of interstitial growth. So anytime you're looking for something that can push, you're always looking for something that soft tissue can grow interstitially. So in the cranium, it's easy. So you can sort of see how the brain's on the inside. As it grows, it displaces the bones. And then subsequent to that, you get deposition at the sutural margins. Make sense? Another way that we know that this happens is that if you get one of nature's experiments where you get premature fusion of the suture, you end up with a head that's a different shape because it doesn't stop the brain from growing. And in fact, if you get total craniostenosis, it's fatal. So surgeons will go in and they'll open up all the sutures in order to allow the brain to grow. So, you know, depending upon which suture you fuse, which suture is fused prematurely, you can see that the head is going to be a different shape. Okay? Because if you fuse this suture, okay, the other ones could still grow. So when we see these premature fusion in pathologic situations, we see that the head, it's not like the brain stops growing. And if all of the sutures fuse, then it's terminal. and the person dies, yes.
So is the process of how it's suturing, like the time period tells you if your brachiocephalic or dolichocephalic?
That's a very good question, and so the question is, and this is something that I've thought about, and that is that, you know, if you're dolichocephalic, it's your brain that's dolichocephalic,
Right.
not your skull. Okay, so because it has to be, the brain is the one who's determining the shape of the bones, not the skull. Now, when we get to the cranial base, it's slightly different in the structure of the cranial base, and we'll talk about that next. But the flat bones of the skull, again, it's one of the easier places to understand, because you can see what the tissue separating force comes from the growth of the brain. It displaced the flat bones apart, and then you get deposition then at the sutures in order to increase the size of the head. So it's a fairly simple sort of construct of what's happening with that. And it just follows those two basic things there. Now, in addition to the, well, there's a huge piece of chalk, that works. Okay, so in addition to the growth of the flat bones, and you know that the growth of the flat bones of the skull, from an embryologic standpoint, the growth of the flat bones of the skull, are they intramembranous or are they endochondral, the flat bones? Do you remember the difference between those two? No? Okay. All right, that's okay. That's why I have these little review sessions. All right, so I don't see the eraser, so I'll have to use it. All right, I don't know where my eraser is. Okay, so remember there's two kinds of bone formation. And we looked at this when we looked at the long bones. We looked at that one type we talked about was when bone is first formed in cartilage and then it's converted to bone. So first starts as cartilage and then it's converted to bone. So embryologically, and this has to do with the embryologic origin. Okay? The embryologic origin. Okay, if it's formed first in cartilage, it was doing better when I first started. Okay, and then it's converted to bone. That type of bone then, this type of bone, is referred to as endochondral. Now, that refers to the embryologic origin of the bone. It doesn't mean that the cells are any different. The bone tissue is still bone tissue. But how it got there is how we call it, the reason we call it endochondral. If it starts as cartilage and then it's converted to bone, we call it endochondral bone. Now, we're not sure, other than the embryologic origin, and for things like the dental boards, it's good to know which bones of the skull are of endochondral origin and which ones are of intramembranous. So if it starts as a condensation here, see if it's the board. I guess our boards are wearing out, that's why we have to. Condensation of mesenchymal stem cells. Okay, so if it starts as just like a condensation of mesenchymal stem cells, undifferentiated mesenchymal stem cells, that then differentiate into osteoblasts and eventually osteocytes, and then together, we would call this bone as a tissue. So if it starts this way as a condensation of mesenchymal stem cells, and then it's basically evolves directly into bone, we call that type of bone intramembranous. Intramembranous. Don't check my spelling. But intramembranous bone. So there's two types of bone that people talk about, intramembranous bone and endochondral bone. Remember, this is what gets confusing when you're going through dental school, is that you're thinking, oh, maybe there's different actually kinds of bone. There really isn't, okay? the different kinds of bone, you know, we could talk about fetal bone, and we could talk about cortical bone. That has to do with the histologic structure. Okay? When we talk about endochondral bone or intermembranous bone, we're talking about its embryologic origin. So the flat bones of the skull are all of intermembranous origin. They're all of intramembranous origin. So the parietal, and the temporal, and the occipital, and the frontal, all of those bones are of intramembranous origin. Okay? So right now, you just have to know that, right? There's no way to figure it out, you just memorize it. Later, you'll see that there are some pathologic conditions that only affect endochondral bone formation and don't affect intramembranous bone formation. And then you'll see, well, that creates achondroplastic dwarfs, for example. Okay, so if you look at an achondroplastic dwarf, and you know that achondroplasia only affects endochondral bone formation, you would know that the thickness of the bone, the thickness of their bones is probably the regular thickness, right? It's the length of the bones that's affected. Why? Because we learned last time that the length of long bones is determined by endochondral bone formation at the epiphyseal growth plates. So the reason why we learn about the embryology is later we're going to talk about pathology. And because the pathology is sometimes related to the embryology, it's good to know that now. So, all the flat bones of the skull are intermembranous, and now we're going to get to the cranial base. The cranial base. And the importance and the significance of the cranial base to growth and development is that the face is essentially built on the cranial base. The foundation for the human face is the cranial base. The cranial base is the interface between the brain and the face. Okay, that's the base where everything's built upon. So the cranial base, interestingly enough, the cranial base now has three parts. And of the skulls that are going around, the ones that are cut in half, you can sort of see the cranial base. The one that's the hole, you have to turn it around. It's not that easy to see it. But the cranial base is made up of three bones, basically. The ethmoid, the sphenoid, and the occipital. Okay? So some portions of the occipital bone are intermembranous and some portions are endochondral. Because you look at the occipital bone, it has the foramen magnum. And the posterior part of the occipital bone here is intermembranous, because it's more like a flat bone. But then as you go, I'm going to take this one off because it's sort of cool. I'm going to just pass this one around because you can see the cranial base from the bottom. We'll sort of pass it around, show it to the camera. Okay. But what you'll see here is that in humans, young humans especially, okay, actually only in young humans, right? Other mammals probably too, but parts of the cranial base are actually not fused together. Parts of the cranial base are actually very similar to epiphyseal growth plates. They're actually, they call them synchondroses. I'm going to hand that to you, just don't, I'm not throwing that one. Okay. So in the cranial base, we've got these things called synchondroses, and they're analogous to, but not exactly like, growth plates. Okay? They actually look like a double growth plate. Okay, they're like a double, like two growth plates side, back to back, they're like smaller, they've got like a histologic thing in between, we can look at them later. But the synchondroses are the closest thing that we have in the face and the head to an epiphyseal growth plate. So, in the skull, in the growing skull, we've got the ethmoid bone, the sphenoid bone, and the occipital bone. So the anterior cranial base is associated, with the ethmoid. The middle part of the cranial base is associated with the sphenoid bone, the body especially, not the wings, right? Sphenoid bone is the most complicated bone in the head. If you can, there was a famous orthodontic chairman who used to make all the residents carve this sphenoid bone out of wax. Because it said if you understood the anatomy and morphology of the sphenoid bone, you understood the anatomy of the whole head. Because it's super complicated, right? I mean, it has the greater wings are here on the outside, right? Then it goes all the way to the inside. You've got the pterygoid plates. There's all these weird things that are all associated with the sphenoid bone. So the sphenoid bone is one of the more complicated bones. We're just looking at the part, I'm basically cutting the skull down the middle. So if you look at this skull right here, it's like I'm drawing just this part right here. Okay, I'm just drawing I'm not even making it wide, right? I'm just cutting it right down the middle like this, and I'm saying the sphenoid bone is out here. I mean, the ethmoid bone's out here, the sphenoid there, and then the occipital. The three parts. I don't know who I stole this from. Did you see it?
I did.
Okay, whoever hasn't seen it, keep these going around. Just as you get them, you can sort of, in your mind, try to get that together. So you've got the ethmoid bone, the sphenoid bone, and then the last part of it is the occipital portion. This is this occipital bone. Occipital. Okay, and then you've got the foramen magnum is here, right? So the foramen magnum. What goes through the foramen magnum? Spinal cord, right? This root, the spinal cord. So that's sort of important. And that part actually doesn't change much. The spinal cord. It's actually pretty solid. When that hole doesn't have a lot of ways to grow. You can get a little bigger by resorption. That's about it. Okay, because there's no sutures there in the occipital and the foramen magnum. So you've got the brain stem extending through that. Now, so anterior to the foramen magnum, we've got the posterior cranial base, which we call this part. We call this the posterior cranial base. And that goes up to the middle of the sphenoid bone back here. And then the part up here, if that's the posterior, then this is the anterior cranial base. Interestingly, just before birth, there's another synchondrosis in between the two bodies of the sphenoid bone. So the sphenoid bone in utero has a synchondrosis. So each one of these synchondroses gets a name. Does anybody know them already? You sort of put the words together, right? So synchondrosis is always the last word, okay? And they're named by the bones. The sphenoidal ethmoid synchondrosis is right here. The sphenoethmoid synchondrosis. So the sphenoethmoid synchondrosis is there. This one is called the inner sphenoidal synchondrosis, and this one is called the spheno-occipital synchondrosis. So the spheno-occipital synchondrosis, the inner sphenoidal synchondrosis, and the sphenoethmoidal synchondrosis. Now, you know that epiphyseal growth plates are there to separate the epiphysis from the diaphysis in a long bone. Okay? So having told you that the synchondroses have a similar function, they're analogous to, but they're not exactly alike, to an epiphyseal growth plate, what do you think happens at the synchondroses?
Remodeling.
Remodeling, endochondral bone formation, but what else? What else happens? What pushes the bones apart? What pushes the bones apart? What pushes the epiphysis away from the diaphysis? Interstitial growth of the cartilage, right? So you get interstitial growth of the cartilage, so we push the epiphysis away from the diaphysis by interstitial growth, and then what happens is we don't end up with these huge, long, pieces of of endochondral, of cartilage, right? We don't end up with big, our bones aren't like huge piece of cartilage. The cartilage gets converted to bone, right? So as you grow, the division in the growth plate separates the epiphysis from the diaphysis, and then conversion of cartilage to bone occurs at that interface so that we get endochondral bone formation. So the tissue separating force in a long bone to grow in length, the tissue separating force comes from the epiphyseal growth plates. So what is the role of the synchondroses now in the cranial base is to create the tissue separating force that's necessary for growth of the anterior and the posterior cranial base. Does that make sense? So its growth at the sphenoethmoidal synchondrosis, you might ask, what about this guy right there, the intersphenoidal synchondrosis? The intersphenoidal synchondrosis fuses right about at birth. It's probably, if it's still there, it's more so that when the head comes out of the birth canal, it's a little more flexible. You wouldn't want to break your cranial base, right? So it's good, it's handy to come out with your cranial base intact and the rest of your brain. So the fontanelles are there so you can sort of squish the head together. Babies when they're first born, their heads are always a little bit goofy looking. You'll notice that when you have kids, don't get all worried. Some people make a helmet for their kid and then straighten it out, but actually they straighten out okay on their own. But that's another story. So, but right before or just after birth, this intersphenoidal synchondrosis fuses. So it's good to know the intersphenoidal synchondrosis, let's just say, fuses at birth. So the intersphenoidal synchondrosis fuses at birth. The sphenoid, from the middle of the sphenoid bone, anterior, called the anterior cranial base, and the occipital bone here with the sphenoid bone, the sphenooccipital synchondrosis, the posterior cranial base. The angulation of the anterior and the posterior cranial base is fixed at birth. This angle between the anterior and the posterior cranial base, people call it the cranial base angle. The cranial base angle is fused at birth. Now, if you remember back to the very, very first lecture that we talked about dolichocephaly and brachycephaly, and I mentioned at that time that different head forms have different angles, cranial base angles, okay? And I said that the brachycephalic individuals have a more acute cranial base angle, and the dolichocephalic individuals then have a more obtuse cranial base angle. So, because the face is built on the cranial base, this angle that's fixed at birth between the anterior and posterior cranial base determines somewhat the morphology of the face. And in fact, some malocclusions, some problems that we see clinically actually have their origin in the cranial base. Okay. As of today, we have no treatments that address the cranial base. Okay. So, last thing that you need to know for today. Well, actually, there's two more things, so don't quite go to sleep yet. Okay. So the anterior cranial base and the posterior cranial base and the cranial base angle. What you want to know is that if the intersphenoidal synchondrosis fuses at birth, a logical question that you would want to know the answer to, and there's no way to know this, so you just have to memorize it, right? You can't figure it out. Remember how I said some stuff we can figure out because it makes sense? And then some stuff you just got to memorize. I mean, there's a few facts you need to know to be a doctor. That's just the way it works. Okay? So one thing you need to know, and you can't be looking it up in a book all the time, but you could, I guess. This fusion of the anterior cranial base between the sphenoid and the ethmoid, the sphenoethmoidal synchondrosis, happens somewhere around 7 years of age. So somewhere around 7, the anterior cranial base, the sphenoethmoidal synchondrosis fuses. Once the sphenoethmoidal synchondrosis fuses, you can't get any more interstitial lengthening, right? So essentially, really, you don't get much lengthening at all, because the bone can't grow interstitially. So the anterior cranial base, as soon as the sphenoethmoidal synchondrosis fuses, sort of that's how big it's going to be. Okay. The posterior cranial base, this one, doesn't fuse, and people say about 13 years of age. There's a lot of variation on this. Could be earlier, maybe as early as 10, could be as late as 18. People say 13. That means after the sphenooccipital synchondrosis fuses, you're not going to see any more increases in posterior cranial base length. Why do we care about that? Well, here's the last thing that I want you to remember. If this is the anterior cranial base, and this is the posterior cranial base, we now want to talk about the maxilla and the mandible. That's our next couple topics, maxilla and mandible. That's why I put cranial base first. I want to see how it works in your minds. Seeming to make more sense to me because we talked about synchondrosis, and they're like epiphyseal growth plates, and so you got displacement, and then you've got remodeling. So if I told you that one of the jaws is related to the anterior cranial base, and one is related to the posterior cranial base, do you know which would be which? This one you can sort of figure out, right? It's logical. The anterior cranial base is associated with the maxilla. And the posterior cranial base, through the temporomandibular joint, is associated with the posterior cranial base. So as we start to understand growth, we know that up until age 7, we get growth of the anterior cranial base, and then we get that effect on the maxilla. What did we call that? If we get growth of the anterior cranial base, we see displacement, primary displacement of the ethmoid bone, but then it carries the maxilla with it, which is secondary displacement of the maxilla. So up until age 7, changes that we see in the upper jaw can be the result of both changes in the cranial base and changes in the maxilla, the maxillary complex. Okay? Once that fuses, now the changes are just the nasomaxillary complex. The same thing then with the mandible. Up until age 13, growth effects on the mandible are a combination of growth in the posterior cranial base and growth in the mandible. So it's confusing, right? Because the cranial base, we know that the face is growing in general this direction, right? And it's displaced downward and forward. But what's happening if the cranial base is here and the cranial base is moving back? Right? So now the cranial base is going one direction, so the articulation of the mandible is going one way, and then the growth of the mandible is going the other way. Okay? Clinically, what do we care about? Well, what's up in front, right? Because that's what we see. We care about coupling the anterior teeth, we care about how the molars fit together, and things like that. So, you always have to remember that everything's changing up until these ages in the cranial base, which is affecting these changes here. Okay. The last thing, now tying it back to the very, very first lecture, and that is that what happens in the brachycephalic individuals that have the more acute cranial base, knowing that the mandible is associated with the posterior cranial base and the maxilla is associated with the anterior cranial base. As we squish this together, we're naturally putting this forward. And that's why brachycephalic individuals have a tendency for class 3. Okay? Doesn't mean they all do. What's the most common molar relationship in brachycephalic individuals? Class 1. That's a trick board question. I've seen it on the boards. They'll say, what's the most common malocclusion in brachycephalic individuals? Well, it's class 1. Absolutely. It just says occlusion or malocclusion. I think a lot of times it says molar relationship, actually. It says, what's the most common molar relationship in brachycephalic individuals? And you know, if you're going, oh, I remember Dr. Hodge was saying class 3s are favored by brachycephaly, it must be class 3. No, I mean, class 3 might go from 7 to 9%, or might go from 7 to 11, but class 1 is still by far the most common, especially overall. Overall, if you just looked at the whole population. If you look at people that see an orthodontist, a lot of the people with straight teeth in class 1 never come. So the population, if you look at a care-seeking population, what's a care-seeking population? Do you know when someone says that? Any idea? Because a lot of our studies in dentistry are done by care-seeking populations. In other words, we don't go out and try to find everybody. We get the people that come to us, and they're seeking something. And then if we start to do a study, they're a care-seeking population. And why do we care about that? Have you had statistics already? All right, let me finish this up and I'll give you some notes on statistics. So brachycephaly would be this, dolichocephalic the same way. Now it's relatively this and that because of the more obtuse cranial base. That's everything on cranial base as far as how the cranial base grows, when it fuses. You need to know that stuff because those are just the basics to understand how the face is growing. Okay? In addition to I draw the cranial base as a two-dimensional structure. It's actually a three-dimensional structure, right? You've got two condyles. It's not just one, right? Now mandibles bilaterally symmetric, usually, at least in general. Okay? So the cranial base also has width. So the width of the face is also determined by the width of the cranial base. So everything is about the foundation. So if you're building something, you start with the foundation. You know, it's got to fit that somehow. Then it can be sort of molded until you finally get down to what we call the occlusal plane, which is in fact where you do dentistry, right? So all the dentistry is done at the level of the occlusal plane. So everything else sums to get to there. Let me just tell you a couple things about statistics that I didn't learn until I was a professor. But I met with a guy who was probably one of the most famous, in fact, he invented genetic epidemiology. This is the father, Robert Elston. And he said a couple things, and his gift was that he was a brilliant statistician, but he actually could speak English, so I could explain stuff to you. Because usually what happens with statistics is people understand the math, but they're not good at telling you stuff, right? So, for example, one of the things, we have extra 5 minutes here. Why is statistics always a percentage? Did you ever think about that? It's never like a number. It's always a percentage. It's always a probability, but why? It's because you have to take a sample. You have two choices when you do a study. You can take everybody in the world, or you can take a sample. Once you take a sample, it becomes a probability. So because you're always dealing with samples, you're always dealing with probabilities. It's always chances are, all right? Chances are. So when you're looking at a study and somebody says the p-value is 0.05, right? And everyone knows that if a p-value is less than, if your number is less than 5, it's statistically significant, right? That's what you say, well, that's statistically significant. But what it really means is this. There's a 95% chance that the difference you found is a real chance. Is really different. But there's a 5% chance you're wrong. Okay, that's what it means. And so it's not so much, oh, that's statistically significant. What it means is always 95% chance I'm right, 5% chance I'm wrong. Okay, it's called alpha error. Now, also there's something called beta error. Does anybody know what that is? You already had statistics, right? Okay. So beta error has to do with when you don't find a difference. So alpha error is when you find a difference, and beta error is when you don't find a difference. So always when you do a study, there's error. It's just a question if it's an alpha error or a beta error. There's always error. There's always a guess. All right? So p-value is alpha. Okay? Beta error, okay, occurs when you don't find a difference. And usually, interestingly, that's set a lot lower. A lot of times at 0.2. So 80%. And this time, it's the opposite thing, right? You didn't find a difference, and 80% of the time you'd be right. But 20% of the time, there actually was a difference and you didn't find it. So always when you do statistics, you've always got this thing of error. You can't get away from it. We can talk more about that later. That's enough for now. It's late in the day. Okay, any questions about facial growth, though? We're good for now? So the next time I'll do maxilla, okay?